we have the session recorded, so people will also be able to access the session. So if that's okay, I'm happy to open the session, and then I'll hand over to our co-chairs who will lead us through today's session. Yes, so hello everyone. Welcome to today's webinar, operationalizing the new WHO guidelines on the management of TB in children and adolescents, and we'll really have a deeper dive into some of the key elements within the guidelines recently released. This webinar has been organized by the Union's Sub-Saharan Africa Child and Adolescent TB Center of Excellence in collaboration with the Global TB Department of the Centers for Disease Control, CDC, and would like also to welcome representatives from the Center of Excellence countries who are on today's call with us. But before we really get started, I'd like to go over a few items so you know how to participate in today's webinar. You might have joined the presentation listening in using your computer speaker system by default. But if you'd like to join over the telephone, just select a phone call in the audio pane and the dial-in information will be displayed. Please also ensure that you're on mute during the presentations, and when you're not speaking. There'll be opportunities for questions at the end of the presentation. We'll save all questions and discussions to the very end of our session. You'll also have the opportunity to submit text questions to today's presenters by typing your questions into the chat panel. You may send in your questions at any time during the presentation. We'll collect these and address them during the discussion and the Q&A session at the very end of today's presentations. And also for the discussions and Q&A, we'll open the floor to allow discussions on the points raised by today's speakers, as well as share Center of Excellence country plans, experiences, and perspectives to operationalize these guidelines, but also be able to identify key challenges, issues, and technical support that our member countries would require to be able to put these guidelines into use. It is now my pleasure to introduce you to today's chairpersons, Dr. Michelle Gassana and Dr. Shrina Satyanarayana. Michael is a medical doctor, public health expert, working at the WHO Afro office as a regional officer for the HIV, TB, and hepatitis unit. He brings over 30 years of multidisciplinary experience in tuberculosis, public health, policy development, and management. Dr. Shrina works as a deputy director of the Center for Operational Research at the Union. He's an Indian national, a medical doctor, and an epidemiologist with more than 17 years of public health experience focused on TB. His core area of expertise is conducting and capacity building on operational research, generating evidence aimed at reducing the policy practice gap. You're both welcome, and over to you, Michelle.
Okay, thank you very much, Dongo. Good morning, good afternoon, and good evening, depending on where you are at the moment. It's a pleasure for me to facilitate this webinar. So, in March 2022, WHO released the consolidated guidelines on management of child and adolescent tuberculosis with an operational handbook, including implementation and monitoring and evaluation considerations, algorithms, dosing charts, and more. The guidelines are based on a careful review of the current evidence and include the new recommendation that strengthen clinical microbiological and radiological diagnosis, introduce shorter treatment option for certain forms of TB, and of course, support the decentralized mode of care. So the integrating these new guidelines or new recommendation into practice would include updating existing national program guidance, adaptation of the country specific context, and implementation at various levels of the health system. I think this webinar will orient members to the new guidelines, highlighting key elements from the operational handbook, aiming at operationalizing these recommendations and dive a bit deeper into key operational guidance to strengthen clinical diagnosis. After the presentation, we'll discuss plans on how to operationalize these guidelines and also technical support needs from all Center of Excellence member countries present on the webinar. Over to you, my colleague, Srinath, to introduce our first speaker.
Thank you, Michael. Thank you, John Paul. Good morning, good afternoon, good evening, everyone, depending upon where you are. Happy to introduce our first speaker today, Annemieke Bruins. She is a technical officer in the TB Vulnerable Populations, Comorbidities and Communities and Comorbidities Unit of the Global TB Program at the World Health Organization, Geneva. Her work focuses on ending TB in children and adolescents. Annemieke, over to you, please, for your presentation.
Thank you very much, Srinath and Michelle. It's a pleasure to be here today. And actually, what I'm presenting is the work that was coordinated by a team of people. So not just myself, but also Dr. Sabine Verkuil, Dr. Kerry Viney, and we also have Dr. Tiziana Mazzini, who's a consultant working with us on in a team. And then I also want to acknowledge all the contributions that many of you on the call today have given during the development of these two new publications. So I'm going to share my screen. Just give me 1 second and put it in presenter mode. Does that come through for you?
Yes, Annemieke, please.
And can you hear me well?
Yes, Annemieke.
Yes.
Thank you.
So today I'm going to take you through some the main programmatic gaps that we face in TB in children and adolescents. Then I'm going to take you through how the guidelines and handbook have been developed. I'll list the new recommendations on TB and on the management of TB in children and adolescents. And then I'll take you through the structure of the guidelines and the operational handbook. So to give you an overview of what these two products contain. And then I will hand over to my colleague, Dr. Sabine Verkuil, who will take you through the new approaches to the diagnosis of TB in children and adolescents. And this covering pulmonary TB, extrapulmonary TB, drug-susceptible TB, and drug-resistant TB. And she will also take you into present to you the new treatment decision algorithms that have been included in the operational handbook. So to start this presentation, I would like to remind you of the large gaps in case detection as well as prevention of TB that we see globally. And these need to be addressed as a matter of urgency. The overall case detection gap has widened in 2020. Case detection for all TB was about 37% in children under 15 years of age, and only 28% in children under 5 years. This means that 72% of children under 5 years are not diagnosed or not reported. The COVID pandemic has had a negative impact on notifications in all regions, and data show that the impact was highest in the youngest children, with a drop in notifications of 28% in the age group under 5 years and 21% in the group 5 to 14 years, compared to an 18% drop in ages 15 years and over. In addition, almost 2/3 of eligible children under 5 years did not receive TB preventive treatment and therefore run the risk of getting sick with TB. And these data were included in the Global TB Report 2021. And we're now in the cycle of collecting the data for the Global TB Report 2022, and that will be over the year 2021. So moving on now to the development of the updated guidelines. WHO held a guideline development group meeting in May and June last year. The guideline development group reviewed evidence on a wide range of PICO questions, covering diagnostic approaches, treatment of drug-susceptible TB, TB meningitis, and drug-resistant TB, as well as models of care. A rapid communication was published in August to flag the upcoming changes. And in March, on the occasion of World TB Day, the full guidelines were published, along with an operational handbook which provides practical implementation guidance on the full cascade of care. The links to these documents are listed at the bottom of this slide. The target audience for both documents include national programs on tuberculosis, but also on HIV, primary health care, and mother and child health services, as well as health workers at various levels of the healthcare, the education sector, and organizations active in the management of TB in children and adolescents. The objective of both documents is to contribute to reductions in TB-related morbidity and mortality in children and adolescents, in line with the global targets in the Sustainable Development Goals, the WHO NTB strategy, and the UN General Assembly high-level meeting targets. The analytic framework used is the pathway of TB infection and disease in an individual child or adolescent, and the interface with or retention across the sequential stages of care, also called the cascade of care, which is shown on the figure on the right, with the corresponding PICO, and PICO stands for Population Intervention Comparator and Outcome, questions used for this guideline update. The next two slides provide a summary of the new recommendations included in the 2022 WHO Consolidated Guidelines. So on this slide, you see the ones that relate to the new diagnostic approaches. So in children with signs and symptoms of pulmonary TB, expert ultra should be used as the initial diagnostic test for TB and detection of rifampicin resistance on sputum, nasopharyngeal aspirate, gaspit aspirate, or stool, rather than smear microscopy or culture and DST. So what is new, because we had already an existing recommendation, but what is new is these two new specimens that have been added, the gastric aspirate or stool. The next recommendation is in children with presumptive pulmonary TB attending healthcare facilities, integrated treatment decision algorithms may be used to diagnose pulmonary TB. This is an interim conditional recommendation. It means that it's valid for a period of 24 months, after which new evidence needs to be reviewed. And then with respect to treatment of drug-susceptible TB, we have a very important and exciting recommendation, which is that in children and adolescents between 3 months and 16 years of age with non-severe TB, without suspicion or evidence of multi-drug resistant or rifampicin resistant TB, a 4 months treatment regimen consisting of 2 months of HRZ with ethambutol or without ethambutol, followed by 2 months of isoniazid and rifampicin, should be used. So that's a major improvement for children. And then we have a new recommendation for the treatment of TB meningitis in children and adolescents with bacteriologically confirmed or clinically diagnosed TB meningitis without suspicion or evidence of multi-drug resistant or rifampicin resistant TB is 6 months intensive regimen consisting of 6 months of isoniazid, rifampicin, pyrazidamide, and ethionamide daily, may be used as an alternative option to the 12 months regimen that we already recommended. And then we have also two new recommendations with respect to treatment of drug-resistant TB. In children with MDR, rifampicin-resistant TB aged below 6 years, an all-oral treatment regimen containing bedaquiline may be used. And in children with MDR, rifampicin-resistant TB aged below 3 years, the laminate may be used as part of longer regimens. And these two recommendations mean that bedaquiline and the laminate can now be used in children of all ages, which makes it possible to use the shorter regimen in children of all ages, and also to build longer regimens for all these children, including these two drugs. It should make it more easy to build such regimens. And the last two recommendations that came out of the guideline development group are related to models of care. And we are very excited about this because it may help to close the case detection and the prevention gaps. And they are as follows. In TB high burden settings, decentralized models of care may be used to deliver services. Oh, sorry, it's going automatically. Just going back. May be used to deliver TB services to children and adolescents with signs and symptoms of TB and or those exposed to TB, and family-centered integrated models of care to deliver TB services may be used in children and adolescents with signs and symptoms of TB and or for those exposed to TB, in addition to standard models of care. So this is very important. They do not replace existing service, but they can complement the services that are already in place. Both the guidelines and the operational handbook follow the cascade of care, as mentioned earlier. This slide shows the topics covered in the various chapters in relation to the cascade of care. The operational handbook covers the following topics. Chapter 1 is an introduction, and then chapter 2 addresses screening and contact investigation, which is actually the first step in the cascade of care. Chapter 3 covers the prevention of TB in children and adolescents, and it includes guidance on BCG vaccination, TB preventive treatment, as well as TB infection control. Chapter 4 is about the TB diagnostic approaches. It covers the diagnosis of pulmonary TB and extrapulmonary TB, both drug susceptible and drug resistant forms, including the use of diagnostic tests and integrated treatment decision algorithms. Chapter 5 is about the treatment of drug susceptible and drug resistant pulmonary TB and extrapulmonary TB. It includes practical guidance on treatment of all forms of TB, including detailed eligibility criteria for the 4 months regimen for non-severe TB, dosing of the new TB meningitis regimen, and also some guidance on post-TB health. Chapter 6 on the models of care to improve TB is on models of care to improve TB service delivery in line with the special needs of children, adolescents, and families. And chapter 7 deals with special situations, including the management of TB in children and adolescents who are living with HIV, the management of TB in pregnancy, and the management of TB in newborns, or the management of newborns of mothers with TB, palliative care for children and adolescents with TB, which is new, care for adolescents with or at risk of TB, and TB in children with pneumonia, and TB in children with malnutrition. Can you hear me? There's some interference. Is it okay?
Yeah, we can hear you. And
okay, okay, sorry. Let me go to the next slide. The consolidated guidelines also bring together the valid recommendations from other guidelines that apply to children and adolescents. This slide provides an overview of the different WHO guideline documents from which relevant recommendations were sourced, including those related to TB prevention and screening, the BCG position paper, guidelines on rapid diagnostics and treatment of drug-resistant and drug-susceptible TB, and TB infection prevention and control, as well as some validated recommendations from the 2014 Childhood TB Guidelines, as well as recommendations from the HIV and nutrition guidelines. All guidelines and recommendations, along with the operational handbooks and training materials, are in the process of being featured on the WHO TB knowledge sharing platform. We are also working on e-courses based on the guidelines and operational handbook, which will be available hopefully later through this year. Let me click. The content of the operational handbook is partly based on existing WHO operational handbooks. For example, those on TB screening, contact investigation and prevention. And in addition, there is newly developed content for topics that were not yet covered in those operational handbooks. For example, on the diagnostic approaches, the treatment of drug-susceptible and drug-resistant TB, models of care, and the special situations. In the handbook, color coding is used for boxes to easily recognize what the purpose of the boxes is. There are green boxes with WHO recommendations, orange ones with specific information, examples and resources, and there are blue boxes in which key points and summaries of key messages are being shown. And these are usually placed at the end of the chapters or the end of sections. So just taking you through the content of the operational handbook. In the section on contact investigation, you will find how to prioritize household contacts and also to give priority to high risk of those at high risk of progression to TB disease after infection. It contains planning and budgeting for strengthening of implementation, some key implementation steps that may be useful, and it gives examples of facility and community-based approaches to contact investigation. Then in the section on TB screening, it gives practical guidance on how to screen child contacts and how to implement symptom screening or a screening with chest X-ray, or how to use them both. Also, how to screen children and adolescents living with HIV based on symptoms and contact screening. And it shows the screening algorithms relevant for each of these groups, either relevant to age or relevant to living with or without HIV. In the section on TB prevention, the operational handbook provides implementation guidance on BCG vaccination. It also, based on the recommendations from the 2018 BCG position paper, it gives information on how to administer BCG and how to manage adverse reactions. Then with relation to TB preventive treatment, it lists the target groups who could most benefit from TB preventive treatment. It goes into detail on how to rule out TB disease before providing TB preventive treatment. It gives information on how to test for TB infection whenever that is relevant. It lists the options for TB preventive treatment by age or HIV status. and how to provide follow-up and ensure adherence and treatment completion. And also it gives criteria on when treatment can be considered as completed. And then with respect to TB infection prevention and control, it lists the recommendations from the 2019 guidelines and focuses on specific considerations for children in high-risk areas. Then in the section on diagnostic approaches that Sabine will elaborate on after my presentation, it gives information on the diagnosis of pulmonary TB, which typical symptoms to look at, how to look at the history of TB contacts, the clinical examinations that would be relevant, but also the atypical clinical presentations that one should be aware of. Then it elaborates on bacteriological confirmation, so the sample types that can be used. It provides information on the WHO recommended rapid diagnostic tests. It gives information on testing for TB infection, the role of chest X-ray, the role of HIV testing, and it includes the integrated treatment decision algorithms for pulmonary TB in children. And then it also includes diagnostic approaches for the diagnosis of extrapulmonary TB as well as drug-resistant TB. In the treatment section, first of all, it goes into deep detail on treatment of pulmonary TB with the recommended regimens and as well as the implementation considerations. So how to assess eligibility for the 4-month regimen that is now recommended based on chest X-ray findings and bacteriological testing and clinical criteria. It goes into the guidance on whether or not to use ethambutol in the intensive phase. It also lists the consideration for the new 4-month regimen that is recommended for children 12 years and older, which consists of isoniazid, rifampicin, moxifloxacin, and pyrazinamide. And it addresses subgroup considerations, for example, when children and adolescents are living with HIV. Then it addresses the treatment of extrapulmonary TB, including TB meningitis and osteoarticular TB. It provides dosing of first-line medicines with the recommended dose ranges, as well as dosing tables for first-line drugs, as well as for the short intensive TB meningitis regimen. It gives practical guidance on the management of adverse events, and as well as on treatment adherence and follow-up and monitoring. It also includes the treatment of drug-resistant TB, so how to identify children with multi-drug-resistant, rifampicin-resistant TB, and it gives an overview of the regimens, the shorter or oral bedaquiline-containing regimen, the longer individualized regimens, the practical approach to regimen design, as well as practical information on the BPAL regimen, which is now recommended from 14 years onwards. And it further lists special consideration for TB meningitis and TB HIV co-infection. And it gives dosing and the formulations of second-line drugs with an updated dosing table in Annex 6. And what is interesting about this is that a subgroup of the guideline development group and has looked carefully at dosing of all second-line drugs for an additional weight band, children from 3 to below 5 kilos. It also provides guidance on how to monitor the response to treatment and what to do in case of adverse effects. And then I mentioned that this is rather new for us, but we have included a section on post-TB health. So post-TB meningitis, post-TB lung disease, post-TB osteoarticular disease, and what to do for children and adolescents who are affected by that, and how to improve their quality of life. Then in the models of care section, it's actually key actions based on the 2018 roadmap towards ending TB in children and adolescents. It provides implementation considerations for decentralized, family-centered, integrated services, which aspects to consider when planning for this, what are opportunities for integrating TB into other services, and some country experiences, as well as project experiences. How to involve the private sector in the care for children and adolescents with TB, again with implementation considerations and some country and project experiences. It also elaborates on differentiated TB service delivery with examples from the PEPFAR solution platform, and it provides guidance on TB in health, on the management of TB in health emergencies, with an example of how that was done during COVID-19. And then lastly, the chapter on special situations. As I mentioned before, this chapter contains practical guidance on the management of TB in children and adolescents living with HIV. So how to screen them for TB, how to prevent the TB in this population group, how to diagnose and treat, the use of cotrimoxazole prophylaxis, and also TB treatment while children are on antiretrovirals, the timing, the choice of the regimen, the adjustment with TB treatment and TB preventive treatment. In the section on TB in pregnancy and management of newborns, of mothers with TB disease, it provides practical guidance on TB screening in pregnant women living with HIV, congenital and neonatal TB, the management of asymptomatic neonates, of mothers with TB. And then in the section on palliative care for children and adolescents with TB, it provides actions to promote accessibility and availability of palliative care, and how to manage symptoms to relieve suffering. In the section on care for adolescents with or at risk of TB, this section is based actually on the 5 domains of adolescents' well-being, which are good health, connectedness and contribution to society, safety and a supportive environment, learning, competence, education, skill and employability, and agency and resilience. And it provides actions to make TB services more adolescent friendly, but it also gives practical guidance on how to engage adolescents in their care. In the section on TB in children with pneumonia, it provides considerations of TB as part of pneumonia guidelines, and it lists the findings from the TB Speak Pneumonia study. In the management of children with TB and malnutrition, it elaborates on the diagnosis and treatment of TB in children with malnutrition, and how to provide nutritional care for children who have TB. So the last slide is about the annexes to the operational handbook, where you will find some selected resources on child and adolescent TB, where there is practical guidance on tuberculosis skin testing, administration, reading and interpretation. There's practical information on sample collection methods. There are standard operating procedures for sample collection methods. The treatment decision algorithms are included also in Annex 5, and that is done so that they can be printed as a job aid. Annex 6 includes the dosing of medicines used in second-line multi-drug resistant TB regimen by weight band, and the table actually goes from 3 kilos to just below 46 kilos. And in the future, this is going to be on the knowledge sharing platform in the treatment guidelines. This will become part of one big table for all ages. And Annex 7 will gives an overview of options for neurocognitive and functional testing at the end of treatment for TB meningitis. So I hope this gave you some detailed insight into what was published in March. And we hope countries will benefit from all of this to update their own guidelines so that children and all adolescents of all ages will benefit eventually from all of this. Thank you very much. And I'm handing over to my colleague Sabine Verkuil to take you through the new approaches to the diagnosis of TB in children and adolescents. I'll first stop sharing, I guess.
Okay. Thank you very much, Annemiek, for your good presentation. As you said, let us introduce to our next speaker, Dr. Sabine. Dr. Sabine, she's working as a medical officer in the TB vulnerable population, communities and comorbidities unit of the Global TB program at the World Health Organization. She's working with Annemiek and they're coordinating the work on the new guidelines and operational handbook of this management of TB in child and the adolescent. So if you are ready, you are welcome, Sabine.
Thank you so much, Michel, for that introduction. So I'll continue taking a little bit of a deeper dive into diagnostic approaches. You've heard from Annemiek all the topics that the operational handbook covers, so I'm sure we can organize a couple more webinars to take you through that. But for today, we wanted to focus on diagnostic approaches. So I hope you can see the screen. I'll put it in full screen, if it works. There we go. I hope you can see that.
Yes, thank you.
Okay, great. So let's take a bit of a deeper dive into diagnostic approaches. And Annemiek already spoke about this new recommendation, which is really on the use of Expert Ultra on pediatric specimens. We already had a recommendation on the use of Expert Ultra on of Expert NTB RIF on sputum, nasopharyngeal aspirate, gastric aspirate, and stool, and then one on the use of Expert Ultra on sputum and nasopharyngeal aspirate. So this recommendation really adds the two specimens, gastric aspirate and stool, to the recommendation on Expert Ultra. In the remarks, you can see that although there was no evidence available on the accuracy of rifampicin detection of rifampicin resistance, the previous recommendation was extrapolated to also apply to stool and gastric aspirate. And then, of course, considerations around the feasibility and acceptability of implementation of the various specimens are need to be taken into account. And then the other recommendation, as Annemiek already mentioned, is an interim recommendation on the use of integrated treatment decision algorithms in children with presumptive TB who are attending healthcare facilities to make a decision to start TB treatment for pulmonary TB. And this recommendation is valid for 2 years, after which we need to review new evidence. And an important remark is to seek bacteriological confirmation whenever possible, in line with the recommendation on rapid diagnostics. So the Chapter 4, as you've seen in that overview of what all the topics are that are covered in the operational handbook, Chapter 4 covers diagnostic approaches, and you can see the part of the pathway that is covered. And it's I can hear someone else. Maybe everybody can just stay muted. Thank you. So it's important to note that following a consultation on the classification of intrathoracic TB, children in September last year, intrathoracic lymph node TB is now classified as pulmonary TB and no longer as extrapulmonary TB. Maybe the host can help to mute people. Okay, great, thank you. So the operational handbook also provides details on the typical symptoms, and of course the most common symptoms of TB are listed on this slide and include cough, especially if persistent and not resolving, prolonged fever with or without night sweats, not eating well, anorexia, weight loss or failure to thrive, unusual fatigue, reduced playfulness or decreased activity. And then the history of TB contact, of course, is very important as well as in children that can be in the household or outside of the household. And then there's guidance on clinical examination for suggestive signs and looking at atypical presentations, for example, acute severe pneumonia or fixed airway wheezing. And then the handbook has some useful illustrations. For example, on the left, there's an illustration of different cough patterns, which may be useful to visualize how a persistent non-remitting cough presents. And then on the right, an example of abnormal growth curves suggestive of TB, which may help identify patterns of growth faltering or failure to thrive. So these are some of the illustrations included in the handbook. Then, of course, despite the challenges with bacteriological confirmation of paucibacillary TB in young kids, every effort should be made to establish bacteriological confirmation. Adolescents usually have adult-type disease, so their bacteriological confirmation is common. And bacteriological confirmation is even more important for children and adolescents who have presumed drug-resistant TB, who are living with HIV, or who have complicated disease like airway obstruction, pneumothorax, or empyema, or severe disease. Also those who have an uncertain diagnosis, or those who have been treated previously for TB. Then there is a section on the recommended clinical samples for the diagnosis of pulmonary TB using expert MTB-RIF or ULTRA. They include sputum, which can be expectorated or induced, gastric or nasopharyngeal aspirates, and stool. And other molecular WHO recommended diagnostics using respiratory samples have only been validated on sputum. And each of these specimen types have distinct advantages and disadvantages. In the handbook, we regard stool as a respiratory sample because children are swallowing their sputum and the bacilli travel through the intestinal tract to come out in the stool where they can be detected for the diagnosis of pulmonary TB. There's also a description of two common stool processing methods and details and experiences on nasopharyngeal aspirate. Also, there's further details about stool processing in a manual that has recently been published by WHO and the Global Laboratory Initiative, and there's the details on this slide where you can access that manual. And the slides, I think these slides will be shared after the webinar so that you can have a look at that again. Then testing for TB infection using TST or IGRA is useful to support a diagnosis of TB in children with suggestive clinical features. Those, especially if they're sputum smear negative or ultra or expert negative, and those who cannot produce sputum. But we need to realize that a positive test for TB infection indicates prior or current infection with TB and is not a diagnostic test. It can also not distinguish between TB infection and TB disease. As Annemieke already said, we have an annex in the handbook, Annex 2, which really looks at details on TST administration. Then there's a section on the role of chest X-ray, recognizing that chest X-ray remains an important tool in the diagnosis of TB in children, especially those with negative bacteriological tests or where testing is not available or not feasible. And most children with pulmonary TB have radiographic changes that are suggestive of TB. If possible, in children under 5, AP and lateral films should be obtained, and in older children and adolescents, PA films. And then there's a description of the abnormalities that are suggestive of TB, which include large perihilar or peritracheal lymph nodes, dense alveolar opacities in a child who's not really acutely ill, and then a miliary pattern, cavitation, pleural or pericardial effusion in a child or adolescent who's not acutely ill. And just to let you know, and I'm sure you're aware of that, I think there was a webinar not so long ago about the recently published Diagnostic Chest X-ray Atlas, which really provides a very practical approach to interpreting pediatric chest X-rays. And the images here have been taken from that atlas. And the link is to the document is at the bottom of the slide. So let's look a little bit more in more detail at the treatment decision algorithms. And in next slides, we'll take a deeper dive into those algorithms that are included in the handbook. It's important to note that the recommendation in the guidelines is a general one and an interim one, conditional, on the use of integrated treatment decision algorithms in general. And following the GDG meeting, 2 new evidence-based algorithms were developed by the evidence reviewers in consultation with the GDG subgroup for inclusion in the handbook. And some of the GDG members are on this call. So there are 2 algorithms in the handbook. Algorithm A is for settings with access to chest X-ray, and algorithm B for settings without. And they're mainly aimed at primary healthcare level to build confidence and capacity to make decisions on starting TB treatment in children. The methodology for the development of the scoring part of the algorithms was prediction modeling based on an individual patient database, around 5,000 records from diagnostic studies. And the sensitivity cutoff that was set was 85%, and that really applies to the scoring section, which is the yellow blocks in the algorithms, with a corresponding specificity of about 37% in algorithm A and 30% in algorithm B. And then again, that only applies to the scoring sections. And then additional steps in the final algorithm were included, like a triage step to manage urgent problems that need referral or urgent medical attention. Also a risk assessment, treatment for alternative diagnosis if the child is at low risk of progression, and bacteriological testing, really to improve diagnostic accuracy. And as Annemieke said, detailed guidance and examples are included in the handbook with a printable job aid in Annex 5. So looking a little bit more deeply into what the algorithms look like now. So basically it starts with suggested symptoms, unremitting symptoms, more than 2 weeks, cough, fever, anorexia, weight loss or failure to thrive, fatigue, reduced playfulness and decreased activity. And then there's an assessment on whether there are danger signs. And for children under 5 years, these danger signs are as per the IMCI. And for children 5 to 10 years, they are as per the ETAT, which is the Pediatric Emergency Triage Assessment and Treatment. Then there is a step to determine the risk of rapid disease progression. Children who are at high risk are those who are aged under 2 years, living with HIV, or who have severe acute malnutrition. And then children at lower risk are All others, so above 2 years, those who are HIV negative and do not have severe acute malnutrition. So based on that risk assessment, children at high risk of TB disease progression should go through the algorithm immediately. And the next step is then to collect appropriate specimens for molecular WHO recommended diagnostic testing and LF-LAM for a child living with HIV, if that's available. If it's not available or there's a delay expected in obtaining the results, the children should continue to the next step. For children who are at low risk of disease progression, they should be treated for the most likely alternative diagnosis, for example, asthma, pneumonia, pertussis, or malaria. And if symptoms persist or after 1 to 2 weeks, they should also go to the next step of the algorithm, which is the collection of specimens, as for the high-risk children. Then the next step would be to look at the result of the MWRD testing or LF-LAM. If positive, obviously those children need to be started on TB treatment. If it's negative, not done, or there is a delay expected in receiving the results, you should continue in the next steps. And the next step is determining whether there is a close or a household TB contact in the past 12 months. And if so, that child should also be started on TB treatment. If there's no contact, you would continue the next step, which is the scoring of signs and symptoms and chest X-ray features, depending on the availability of chest X-ray. So for algorithm A, the scoring of signs and symptoms is done. And when a sign or symptoms that is on this list is present, based on clinical history and physical examination, the corresponding score is noted, and then the scores are added up. And if this, for the scoring of chest X-ray features, that works the same way. If the features present, it's noted and added. And it's important to note that chest X-ray can be done at any point in the evaluation in parallel with or after scoring signs and symptoms. And it's quite important for assessing severity. Then for algorithm B, which is the one without chest X-ray features, again, the scoring of signs and symptoms is then done. When it's present, the score is noted and the scores are added up. And it's important to note that the scores for clinical signs and symptoms are different in algorithm A and algorithm B. And then obviously, if the total score for algorithm A is more than 10, so the combination of signs and symptoms and chest X-ray features, that child should be started on TB treatment. If the score is 10 or less, the child would need to be reassessed after 1 to 2 weeks. And for algorithm B, if the total score from signs and symptoms is more than 10, again, that child should be started on TB treatment. If not, the child would need to be reassessed. So in the handbook, there are some examples of scoring. For example, here for algorithm A, if you have a child with a cough for 3 weeks, he would get 2 points for that. Lethargy, 3 points for that. Tachycardia, 2 points. None of the radiological features on chest X-ray, the points would be 7 in total. So that child should not start on TB treatment and needs to be treated for the most likely alternative diagnosis and then be reassessed in 1 to 2 weeks. However, if the child presents with weight loss, it gets 3 points. Swollen lymph nodes, it gets another 4 points. And opacities on chest X-ray, which gives him 5 points. He would have 12 points in total and would need to start on TB treatment. And a second example for algorithm B, a child with a cough for 3 weeks would get 5 points. Fever for 5 days would not get points as the duration is less than 2 weeks. And fast breathing, which gives him another 2 points. He would have 7 points in total and would not start TB treatment. and again needs to be treated for the most likely alternative diagnosis and be reassessed in 1 to 2 weeks. Then, if a child has a cough for 3 weeks, again 5 points, weight loss, also 5 points, and swollen lymph nodes, let's give similar as 7 points, he would have a total score of 17, in which case the decision to start TB treatment needs to be made. Then, after making a decision to treat a child for TB, there are 2 assessments that need to be made. The first one is an assessment for risk factors for drug-resistant TB. For example, if the child has contact with a confirmed or presumed person with drug-resistant TB, or has a poor response to first-line treatment after 2 to 3 weeks, 2 to 3 months, or previous TB treatment in the past 12 months, that child would need to be referred to the appropriate level of care to try and confirm drug-resistant TB. And then the second assessment is for severity of disease, which really informs the duration of treatment, in line with the recommendation that was mentioned by Annemieke, that children with non-severe TB should be treated for 4 months rather than for 6 months. And non-severe TB is defined as intrathoracic lymph node TB without airway obstruction, uncomplicated TB pleural effusion, or paucibacillary non-cavitary disease confined to one lobe of the lungs and without a miliary pattern. And further details obviously is provided in the operational handbook. We also have a separate presentation on treatment, but obviously we won't have time to go through that today. So children with non-severe drug-susceptible TB should receive a 4-month treatment regimen, which is the same composition as the currently the currently used treatment regimen, just the continuation phase is 2 months shorter. So in terms of the diagnosis of extrapulmonary TB, the handbook provides the details on WHO recommendations on the use of expert and ultra on non-respiratory assessments. It provides the typical clinical features of the different forms of extrapulmonary TB with the investigations that really depend on the site of disease that is affected. And then for drug-resistant TB, the clinical presentation is very similar to drug-susceptible TB, but it's very important to really attempt bacteriological confirmation using molecular WHO-recommended diagnostic tests. And a clinical diagnosis, of course, can be made based on suggestive signs and symptoms and a suggestive chest X-ray with a history of contact with a person with drug-resistant TB. And then, of course, the drug susceptibility pattern of the source case is very important. So in the box on the right, you see when to suspect drug-resistant TB in a child or adolescent, especially in if that child has been in contact with a person with confirmed drug-resistant TB or presumed drug-resistant TB, for example, someone who failed treatment or was retreated for TB, or someone who died from TB. Also a child or adolescent with TB who is not responding to first-line treatment after 2 to 3 months, despite good adherence. And if the child is living with HIV, IRIS is an unlikely diagnosis. And also in children or adolescents who were previously treated for TB, who now present with recurrence of disease. This could be either a true relapse or reinfection. So just to end with the key messages around diagnostic approaches. Bacteriological testing needs to be prioritized for children and adolescents with presumptive TB, and the choice of specimen really depends on the acceptability and feasibility of implementation in the local context. So for national programs who are updating their guidelines, it's important to take these local factors into account. And then recognizing that young children typically have post-subsidiary TB, and clinical diagnosis is very important. If bacteriological tests are negative, not available, or cannot be done, and really then based on signs and symptoms, TB exposure and chest X-ray available, and starting treatment not be delayed into with the clinical diagnosis. Then TB infection tests, TST and IGRA, do not distinguish between infection and disease, and a negative test does not rule out TB. And the important new strategies in the guidelines and the handbook are the recommendations for expert MTB-driven ultra testing of stool and other specimens in children, and the use of stool as a sample potentially allows for broader access to bacteriological testing because it's a non-invasive specimen. Then the use of the evidence-based treatment decision algorithms, as we discussed today. And then the determination of severity of TB disease, which is really important to guide the use of the new 4-month treatment regimen for non-severe TB. So we'd like to acknowledge the rest of the team, Kerry Viney and Tiziana Massini, and of course also our director, Dr. Teresa Kazaeva, our unit head, Farai Mavunga, and other colleagues from the WHO Global TB Program, and then all experts who contributed to the development of the guideline and the handbook, including the guideline development group, the external review group, technical partners and funding partners, and of course the members of the Child and Adolescent TB Working Group. So thanks very much for your attention, and it will be great to hear about how countries and programs are planning to implement these new guidance, and what possible barriers or challenges may be that need to be overcome to make this possible. Thank you so much.
Thank you, Sabine, for your excellent and clear presentation. I have a request for the participants or the audience of this webinar. Please note that you can post questions for any of our speakers in the chat box at any time during this webinar. Now let me invite Professor Steve Graham, who will be moderating our next discussion session. Professor Steve Graham is a pediatrician based in Melbourne, Australia, with appointments with the University of Melbourne and the Burnet Institute. He has clinical and research experience in TB in the Asia Pacific region and Africa. Professor Steve recently co-chaired the Guidelines Development Group for WHO's Consolidated Guidelines on Child and Adolescent TB. He will be facilitating the discussion during the next session. So welcome, Professor Steve, and over to you, please.
Thanks very much, Srinath, for the kind introduction. Thanks very much to Annemieke and Sabine for your excellent presentations. I would like to just point out, I think we're all aware, but I think it's worth saying that quite a lot of the evidence that informed updates of guidelines were from research studies that were undertaken in the African region, in countries such as Uganda, Zambia, South Africa, etc. And so I think it's a credit really to the work that's being done in the region. So we'd now like to open the floor to the representatives of the Centre of Excellence member countries to discuss these plans to operationalise guidelines and identify key challenges, issues, and technical support needs. John Paul pointed out earlier that you can use the Q&A or the reactions by putting the hand up. So if you could all help me keep an eye out for those, that would be great. And I guess, given the context of those presentations, I guess one question I'd like to ask people from the member countries really is, to start with, do you have plans to update the child and adolescent TB guidelines is this timely? Is this something that you may be doing this year in the near future? And will this be incorporating these latest guidance from WHO? So looking forward to hearing from the member countries' representatives.
Steve, there's a question in the there's a question in the chat, and it's coming from yeah. So the question reads: has the handbook included management of TB infection, which has been determined by only a positive KFT without any symptoms or non-TB contact? This is in line with the instance of research setting where KFT is a part of study tests. Over.
Yeah, I'll let Sabine respond to this, but just remember that this is the WHO Consolidated Guidelines on Child and Adolescent TB. The first module 1 was actually the WHO Consolidated Guidelines on Prevention, Tuberculosis Preventive Treatment, which really focused very much on the management of TB infection. And as I understand it, these current child and adolescent TB guidelines have incorporated all relevant information that relates to child and adolescent TB from those TB infection guidelines. So perhaps Sabine or Annemieke, you'd like to speak to that.
Thanks, Steve. I was just trying to type a message, but of course that takes a little bit of time. So as Steve is saying, it's the handbook is really consolidating all the operational guidance that was already available. For example, from module 1, which is on prevention, module 2, which is on screening, and current guidance is that for household contacts over the age of 5, TPT may be used as well, and there the IGRA tests are important, ideally to establish whether an infection is indeed there or not, but I think the main entry point is really the history of contact of a child or adolescent with someone with infectious TB. Of course, it's sometimes not quite known whether there's been contact in the community, for example. So if especially an older child has a positive IGRA without symptoms, that child may be given a TB preventive treatment, and then ideally one of the newer, shorter regimens. So that is definitely an option. I hope that answers the question.
Yeah. Thank you, Sabine. The next one in the chat is, shall we be given the slides? And I think the answer to that, John Paul, is yes. But Adam Mandala has a number of questions, and I'll ask the first. Apart from the disease severity score, are there any other indicators for selecting a 4-month regimen in pediatric population? So this is reference to the shorter regimen for the SHINE trial. And the disease severity score, I hope we don't confuse the two. There was a score that Sabine has just talked about, which is in the clinical management algorithm and helping you make a clinical diagnosis. But in terms of disease severity, such as for non-severe pulmonary TB, characteristics included are radiological and as well as bacteriological. So not smear positive, for example, pathology confined to one lobe, very much following the same as the SHINE trial did. So there are clear indicators in the operational handbook, and there is the Union Union Chest X-ray Diagnostic Atlas that Sabine referred to as well, to help define non-severe TB for the 4-month regimen. Sabine, did you want to speak more to that, or?
Yes, thanks, Steve, and thanks for the question. So indeed, there is quite detailed operational guidance in chapter 5, which is on treatment. So I think it's important, as Steve is saying, to separate the treatment decision algorithm scores from the decision around the severity and the duration of treatment. So the treatment decision algorithms are really designed to help make a decision to start TB treatment in a child. And then once that decision has been made, it's important to determine the severity in order to inform for how long that child needs to be treated, for 6 months or for 4 months. So for children with non-severe TB, they can be treated for 4 months. And as Steve is saying, that can be based on radiological features. So according to the definition as we've just given, but there's also bacteriological features that can be taken into account. So these children would need to be smear negative or expert negative trace, very low or low semi-quantitative results. And then, of course, there are also situations where you don't have access to a chest X-ray or to bacteriological testing. So for those situations, the decision on severity can also be made based on clinical features. So that is all detailed in chapter 5 of the operational handbook. Thank you.
It's a great question, because I think we anticipated that in terms of the elements which might be challenging to implement. I think the 4-month regimen seems to make things simpler, but it will be challenging to apply it. There is a now move to 4-month regimen in adults as well, and national programs will, I guess, have to start to consider a different regimen, but there is shortening of regimens. This is an important step, and I guess this is something that national programs will have to get their head around as to how it's going to require education, teaching, training, etc. It's going to take time. I'm not sure whether in WHO you've had further discussions about the application of changing regimens for drug susceptible, drug resistant, as regimens are becoming shorter, perhaps. So, any news about TB infection treatment amongst MDR-TB contacts and what's the available evidence? So I think the answer to that at the moment is that we're still waiting for the results of a number of randomized clinical trials, and that the results are not too far away. There's one study in Vietnam, mainly of adults, that's definitely completed all follow-up and is now being analysed. And there's a study in South Africa of young child contacts. Both of those use fluoroquinolone, levofloxacin for 6 months. There is another study that uses delamitid in comparison to isoniazid, and that study, the results won't be in for a few years. But in the meantime, there are WHO guidelines, conditional recommendations to follow, which are in the previous Module 1 prevention consolidated guidelines. And again, I think repeated in the child and adolescent TB guideline. So at the moment, on the basis of risk, if a test for infection is available, it should be done. And for a high-risk child, such as a young child contact under 5 of somebody with fluoroquinolone-resistant TB, fluoroquinolone-sensitive drug-resistant TB, then they can be given 6 months of levofloxacin as preventive treatment. But we're still waiting for the higher quality evidence to inform updated guidelines. And I presume, Annemieke, that these guidelines would be updated once the high quality evidence will come through. Yeah.
Absolutely, and it may be done by the colleagues responsible for prevention in the Global TB program, but then we will need to align our module based on this latest recommendations in the other modules of the knowledge sharing platform. But it seems to me that there is interest in another session, a future webinar, looking more at all the treatment. Well, today we were asked to really focus our presentations on the new aspects of diagnostic approaches.
Yeah, but it's an important question. So we'll watch this space. Adam, did you want to ask any further questions at all? You've asked a couple of questions. Did you have comments at all about in your country, your preparation to adopt any of these guidelines? We've just, these consolidated, updated guidelines?
No, I'm at the regional level. Thank you. Thank you. First of all, I would like to thank all for the nice presentations, and being at the regional level, I can't have much on the issues of the country approaches in adaptation of new proposed guidelines. But the response to my last questions is very, very good, and I'm satisfied with the response. Thank you.
Thanks, Adam. We also have a question from Kazani Bendera, and it's about apparently lots of questions still going around about why streptomycin's been removed in the treatment of meningitis, and what is the most appropriate response to such a situation. I think for some time now we've realized that streptomycin first is not a strong anti-TB drug, and there are now better drugs. Streptomycin doesn't penetrate the CNS, the CSF, and so is not a great drug on a number of accounts. And it also can be associated with quite a lot of toxicity issues, such as ototoxicity, hearing loss, requires injections for long periods of time. There are better drugs now that will penetrate the CSF and are associated with better outcomes than the old treatment regimens. And that's the reason why the TB meningitis guidelines have been updated. So streptomycin is really no longer recommended as an anti-TB drug. The fluoroquinolones are better at crossing the blood-brain barrier, for example, as is ethionamide. And there's discussions around increasing the doses of isoniazid and rifampicin within safety. So these are all discussed in the operational handbook. I'd urge you to look at the management of TB meningitis and the update. But in South Africa, where they've for quite a long time used a 6-month regimen of daily rifampicin, isoniazid, pyrazinamide, and ethionamide, they have reported better outcomes than using the longer standard regimens. So that's one reason why this is now an alternative regimen that's recommended. So Uganda, from Maureen, she started the conversation with the stakeholders and planning to consolidate. So Maureen, please speak to us about your plans in Uganda. Thank you.
Yes, thank you very much. Are you able to hear me?
Yes, thanks, Maureen. Yeah.
Yes, greetings to all of you, and thank you for this session. Great presentation. So the guidelines were published at the right time. We've been waiting for them since 2021, and they came at a point where we were planning to enhance subnational level capacity for TB, building upon the initial scale-up of the district approach. We are scaling up to additional districts, so we needed to enhance the capacity. So they were also published at the time when we were having our quarterly committee meeting that had been scheduled at that time. They gave us the opportunity to introduce the concept of updating the guidelines and aligning to the current recommendations. the TB program has developed a roadmap to update the guidelines over time. And we are looking at having these disseminated during World TB Commemoration 2023. So that is the target that we are aiming at. The other critical issue is about the algorithm and the fact that the current guidance WHO provides for collection of data, and this is the interim guidance. So the proposal is to learn from a few facilities as we generate evidence to improve the algorithm, and probably this would not be finalized before the World TB Day 2023. So the general thinking is that we give it more time as we document and learn, and that is specific to the algorithm. We plan to have further discussions regarding the adaptation for the shortened regimen, because there are several implementation considerations. So as we, upon conclusion of the roadmap, we shall conduct stakeholder consultative meetings where the evidence will be provided vis-a-vis the local context, and we shall be able to come on the same page regarding the next step. As far as the non-invasive sample procedures are concerned, school is one of the priority areas, and there are steps by the National TB Reference Lab to document evidence on the use of stool within the local context, and that will also guide rollout at the country level. Thank you very much.
Thanks, Maureen. And I presume that you'll be happy to share your experience from Uganda through this group and with the Centre of Excellence. Is there anyone else from another country also planning with guideline updates planning? And if so, could write in the chat and then we can get you to speak to it. In the meantime, there's we'll come back to the question around isoniazid monoresistance by Kazani, but Mr. Muva has questioned about how do the guidelines show ways to maximize capture of the misdiagnosed? I mean, that's absolutely critical, is improving case detection and also accuracy of clinical diagnosis. The various ports of entry into healthcare for these children and adolescents. So I think that's really very much at the core of these guidelines in many ways, with decentralization, strengthening clinical diagnosis and approaches, and also really very much at the core of this Centre of Excellence activity. But yeah, would you like, sorry to keep going back to you, Sabine, but would you like to speak to that?
Yes, thanks. I think indeed that is something that these guidelines, and especially the operational handbook, is really trying to address. And the reason why there is so much attention to those treatment decision algorithms is really to build that confidence and capacity in making a clinical diagnosis, or using all evidence that is available to make a decision about starting treatment in a child. And that's really especially for the primary healthcare level. And with that, of course, that would be applicable to various entry points as well. And that is then further strengthened in the chapter on models of care, which really talks talk about integration in different entry points with maternal and child health services, HIV services, nutrition, general primary health care, and decentralizing to the lower levels of care to really ensure that these children are found and diagnosed early so that they don't progress to severe forms of TB. I mean, in the recent program review in Kenya, it was highlighted by some of the specialists that were working at tertiary level that really the severely ill children that they see at the tertiary level with TB meningitis and disseminated forms of TB are really an indication of the missed diagnoses at the lower levels. Because if we can find those kids earlier and start them on treatment, they will be fine. They will not progress to such severe forms of TB. So I think that is definitely something that we've tried to really address and emphasize in these guidelines and handbook. And Annemieke may want to add.
Yes, thank you for that, Sabina and Steve. And this will require initial investments, and that was acknowledged as well during the guideline development group. But if you build that capacity in the long run, it should be, it really has the potential to prevent severe morbidity and also mortality. And we have also been presenting at various Global Fund related events, and it seems that the donors are willing to make investments in helping countries rolling out decentralization, integration. The thing that is very important is that countries update their national strategic plans, but also that they request support, because if they don't request, then the donor cannot provide. So we are there to help, and maybe countries can also make use of the multi-sectoral accountability framework, in which different stakeholders, programs are getting together at country level, adding a component to it to discuss how to improve the management of TB in children and adolescents, what is needed, where it's needed. Of course, countries cannot do it everywhere, at every primary healthcare, at every IPD or at every OPD, but it will all start with an assessment and then step-by-step roll out. And of course, what is most essential is sufficient number of healthcare workers, and healthcare workers that feel confident and have the skills to either manage the children themselves or to be aware and refer them to an adequate level in the healthcare system. Thank you.
Thanks very much, Annemieke. I'd like to speak to the, Sabina's put an answer in the chat. We'll come back to the discussion around isoniazid monoresistance. Earlier question, it's important, but we were talking about contacts of MDR cases, and the question that Saumu's put there is really around this study of delamanid and isoniazid. So it's not a study of delamanid and isoniazid for prevention, it's a study of delamanid in one arm of the study, and isoniazid is the control arm, if you like. And this is not just young child contacts, and there's two reasons to think. Remember that in any contact screening, when you do a skin test, for example, or a test for infection, that test for infection cannot tell you whether that person's been infected with a drug-resistant strain or a drug susceptible strain. And so there's a standard of care that if you should at least provide isoniazid, which is the current recommendation, in one arm, and then see whether delamanid can have an improvement in those who are in the household. But you can't assume, for example, if somebody's got a test for infection that's positive, that they necessarily were infected in that household from a drug-resistant case. So that's one rationale for doing it. There's also another observation recently from Peru that showed that young children who received isoniazid, who were MDR contacts, still had some protection versus those that did not. And there's a good rationale for that. Drugs can still be effective against infection with very few bacilli, even if they're not so effective when there's multibacillary disease. And so these are some of the reasons behind that. But I think the bottom line is really that the Phoenix study is really testing delaminid. That's the main aim of the study, is to test delaminid against a sort of background approach. Now, we're talking isoniazid resistance, and there's a long question here by Kazani, and she talks to the fact that isoniazid resistance, monoresistance is common, and perhaps it's even more common now that IPT has been used widely, particularly amongst people living with HIV. And, you know, what are the implications of that? So there's two things here. I think there's discussion around testing, such as with Expert. And I think, as you know, the Expert platform is now going to be, or assays are now being developed to test beyond rifampicin, so to include tests for isoniazid fluoroquinolones, and at the moment, aminoglycosides, or perhaps in the future, even bedaquiline. But there is going to be wider testing using Expert for drug resistance, which will be helpful. And I think there will be quite a lot of isoniazid monoresistance identified. However, how that affects treatment is still a bit of an open question. And when it comes to children, I think we get very, very good outcomes. If, for example, you consider the SHINE trial, that was done in 4 countries, India and 3 African countries, and there would definitely be isoniazid monoresistance in those populations. And they're including in India children who are fast acetylators of isoniazid. And yet, even with that regimen, in populations likely to have isoniazid monoresistance, there was excellent outcomes. And it's the same for preventive treatment for isoniazid. The new regimens are not better than isoniazid, they're just as good, but they're shorter and safer. So isoniazid still has effectiveness even in the context of isoniazid monoresistance. And it's about drug dosing, it's about other issues. So I don't think at the moment, I think it will be a study undertaken. I know there are studies being undertaken now, looking at optimal regimens for the treatment of isoniazid monoresistant TB, randomized trials, but of course, as always, they'll be done in adults. And I'm just trying to say from observation, I think we can be fairly reassured that we don't need to change practices in this regard in children at this point. I think we'd need a lot stronger evidence to do that. So I think it's still, isoniazid is still an effective drug, even in the context of rising isoniazid monoresistance. Sorry, that was a bit long-winded, but it is a common question that's asked, and I guess the bottom line is we still need evidence, but at this point we wouldn't be changing. But because, yeah, did you want to speak to that, Kazani, yourself, or other questions that you asked before?
If I would like to,
Go for it. Yeah.
So the problem I have is looking at the data that we have, and I know I haven't done a good job of giving you all the facts, but I would hope that it shows that it's doubled over time, and the only thing that's happened is the isoniazid preventive therapy.
Yeah.
And that being the case, we have a problem with screening. I think a pragmatic everyday problem then in HIV clinics, and probably even amongst our own children. We didn't include children, but it's not hard to imagine that that's a problem as well. So it's those things, those are practical parts of what we do currently that I'm asking about. What are we supposed to do about this? Because I doubt we'll be the last country that you'll see this with. And therefore, I've noticed that in your guidelines, you speak about, the world speaks about expert ultra. But as far as I know, that expert ultra is related to the MTB RIF. And that seems to me to be yesterday's technology. What we really require is that next bit. So what are we supposed to do with this when guidelines, and it seems what's coming up might possibly be behind, at least in our case, what's going on and the possible implications as we see them.
Okay.
Over.
All right. Now I understand, and I think the diagnostics are improving in terms of detection of isoniazid and other drugs. But my point was that at this point, the evidence would suggest that identifying isoniazid resistance may not necessarily directly translate to a poorer treatment outcome using isoniazid. That's the point. And the most recent data from the SHINE trial would suggest that it's still effective as part of a standard regimen. That's the observation at this point, but I understand your concerns. I think time's up for me, so I want to finish here and hand over to Michelle for some closing remarks. But thank you all for your participation. I think this is a sort of discussion could go on for a very long time, but I think it's time to finish up, and I'll hand back to Michelle to make some closing remarks. Thank you.
Hello, Michelle.
Okay, okay, thank you. Sorry. Thank you very much, Prof. Steve Graham, for having moderated very well this discussion session. So we are at the end of our webinar, and we hope that the different presentation made and the discussion during this session have been helpful to everyone, and especially for those who are facing challenges to operationalize WHO guidelines for a child and the adolescent. Now I would like to welcome Amalia King to give us closing remarks for this meeting. And over to you, Amalia. Thank you very much.
Thank you so much. My name is Amalia King. I am in the Global Tuberculosis Branch at CDC. Very happy to be here. I'd like to thank all of the speakers today for sharing their expertise, and for every single one of the participants from our country teams for joining what has been a really, really engaging and thoughtful discussion. We look forward to using our platform at the Center of Excellence to support COE member countries to adopt and operationalize these updated and new WHO guidelines on the management of TB in children as well as adolescents, which of course, both populations are especially important. I am hopeful that if member countries can integrate these guidelines into country-specific practice and implementation, this will definitely contribute effectively to the national child and adolescent TB response. And ultimately, our goal is to save children's and adolescents' lives and prevent TB. So thank you so much, everyone, for joining, and what a wonderful session. Over to you, John Paul.
Yeah, thank you so much, Amalia. Again, I also want to thank Michelle, Sharina, Annemieke, Sabine, Steve Graham for really taking us through such a very wonderful session. But also, of course, again, to also our participants for being able to attend today's webinar. We will be posting the recording of this webinar onto the Union website for your viewing and listening, but also we'll also be able to share the PDF version of the presentations from our colleagues from WHO to all the participants that have been able to attend this this session. And I'll really very briefly, I'd like to do two items. One is really to introduce a new colleague of the Union team. She's called Rita Mandi. She recently joined the Union Uganda team, and she's going to be our point of contact, but also coordinator for COE ongoing related activities. In the coming week, we'll be sharing more details, including her email address with all COE stakeholders. So really, Rita, very welcome to see you joining the COE family. And then lastly, a word or two again to Amalia King. Bidding fail really to Amalia. This is potentially the last webinar that we are holding with Amalia present as part of the COE. We know that in a couple of weeks from now, Amalia will be transitioning from the Global TB Department of CDC to the Immunization Department. Yes, so really, Amalia, it's been great. It's been a great pleasure and an honor working with you on the COE platform, but also all the other CDC related projects that we've been working on together. So we also wish you very well in your new position. And finally, on behalf of the union, our partners at CDC, our presenters from WHO, our facilitators, thank you all for joining us today, and enjoy the rest of the day.
Thank you, everyone.
Thank you.
Thank you very much.
Oh,
you,
goodbye.
Thanks, everyone.
Bye.
Take care.
Thank you. Take care.
Thank you.